First of all, I thank Shivam, Amardeep, Dr. Gaurav, Dr. Saurabh, and the whole team at Dishti Icon for implementing this idea of mix. I had a discussion with Dr. Gaurav when Shivam had joined and when I came for the Glaucoma Glow program that Dishti should conduct a MIGS meeting, and Gaurav took over it, and this meeting has become a big success. Lot of tips of mix from yesterday, and in the wet lab, Dr. Grover's talk, it is being bombarded how to start your mix journey. So this is a simple repetition of what I have an informal talk with everybody in the wet lab. So mastering intraoperative gonioscopy is very, very important as the first step in learning mix surgery. So we all know through what all routes the mixed procedures work. What in India we target is basically the one which works through the trabecular meshwork. And to begin with, we should start with, that Dr. Sunita was asking, which mix to learn first. The first mix to do is bang, because it doesn't involve any investment, any cost, and still you are not confident in performing the procedure. Try to do bangs free of cost so that you first gain confidence. Once you gain confidence, then you can go to KDB and iStents and other procedures. So what are the challenges in mix? The biggest challenge is procuring a gonioscope, which has been overcome to all of you all by what Gaurav has given, the free gonioscope to the wet lab participants. So now you all have the gonioscope. Now the biggest challenge, the first step is overcome, that you have the gonioscope. Second challenge is how to learn gonioscopy. So the challenge in learning gonioscopy is how to identify the trabecular meshwork. That is the biggest challenge. So this is a small video. Can you just lower down the volume? So initially when your cataracts per surgery you are performing, what extra instruments you need to learn gonioscopy is basically a gonio lens, a cohesive viscoelastic substance, a needle holder, a 2 ml syringe on a 24 gauge needle so that we can prepare the bang needle. This is a video showing how to prepare the bang needle. The anterior 0.75 to 1 millimeter of the bevel is bent, less than 90, more than 80. So this one bend should be there, and this is the way you are going to prepare the bang needle. I always advocate a 24 gauge needle and not a 26 gauge needle, because if you use a 26 gauge needle, when you are performing it, the hub of the needle will be hitting the limbus. So the length is not adequate, the normal 26 gauge what to use. Second step is adjusting the position of the microscope and the patient. So the dictum is always when you are sitting temporally or superiorly, the patient's head should be away from you by 35 to 40 degree, and the microscope should be tilted towards you by 35 to 40 degree. Once these two positions is done, and when you place the surgical gonioscope over the cornea, and when you look through it, you get an en-face view of the angle. So this is a picture-in-picture mode of the video which I am showing you. So once the head is tilted and the microscope is tilted, you have to adjust the table height or your stool height also. Once the cataract is done, inject a cohesive viscoelastic into the anterior chamber, place some cohesive visco over the cornea also, and you can place some visco over the lens also, and then place the lens. So this is the walk transient lens. It's a suspended pendulum type of lens. It leads less manipulation of the patient and the microscope. So always try to identify the angle structure first in low magnification after every cataract surgery. Never press the gonio lens, just place it and then introduce the needle in low magnification. Advance the needle tip towards the trabecular meshwork or towards the angle once you identified. Try to rotate the needle, don't pierce it. This is all what you are going to do, how you are going to start learning intraoperative gonioscopy. Once you have identified, try moving the needle parallel so that your wrist, which is stiff, becomes flexible. You know how much the wrist has to be moved when you want to go inferiorly. When you want to come superiorly, how much the wrist has to go again move. Because if your wrist is not flexible, you can't proceed with the procedure properly. So always try to first identify the angle structure in low magnification. Once you have identified the angle structure in low magnification, then increase the magnification. What happens is once you start doing it in the high magnification, the depth perception is reduced. So always first try to identify in low magnification so that you don't get disheartened. You start identifying the trabecular meshwork. This is very, very important. Another tip what I can give you to identify the trabecular meshwork is once you have injected the IOL, wash the visco. Under continuous irrigation, inject trypan blue. So the trypan blue, when you inject towards the angle, the trabecular meshwork gets stained. And after that again wash the trypan blue and put a cohesive viscoelastic, and then you will be seeing the stained trabecular meshwork. So this will be more helpful in identifying the trabecular meshwork. So the dictum is always go with the low magnification, and then once you are confident in it, then go with the high magnification. Now if in the initial stage you don't have the budget of buying a surgical autoclavable gonio lens, you can always go ahead with this disposable lens. This is a Ketina left-handed lens. This has been given to all the wet lab participants today. So you can use this lens clean it properly and ETO it, and you can use it multiple times. So you can look at this lens, it has been reused, there are some scratches on the anterior surface of the lens, but that is the cost. You can get this lens for 3,500 to 4,000 rupees. So the dictum is, again, go with the low magnification, always try to introduce the needle first and then place the gonioscope. Second thing is, when you are doing this procedure, your incisions are very, very important. Make sure that you do corneal incisions. Your side port, your main wound should be always corneal, they should not be limbal. If they are limbal incisions, they will be bleeding, and this blood can come into the interface between the lens and the cornea, and that will obscure your view. You can see in this, I am studying, these are all my learning curve videos. So at the moment I am trying to visualize the angle, I am lifting the lens. The moment I am lifting the lens, the bleeding which was occurring, the blood is escaped into the interface and it is obstructing the view. Sometimes I am pressing the lens. When you press the lens, your angle gets closed. You can't see the structure properly and there will be a wrinkling effect on the cornea. When there is a wrinkling effect on the cornea, that means your angle is closed, you are pushing the lens. So don't push it, always just place it. This is the best lens I can say for all the beginners who want to do mix. This is a Secure Flex biocular hands-free lens. It is like a contact lens. The lens is wider, it goes beyond the limbus, so the two side posts are covered. There is a curtain through which you can pass the instrument through the main tunnel. Your left hand is almost free. But to get a better view, you just have to slightly touch the lens and you can visualize the angle structures much clearly. So almost left hand is all the time free. The viewing angle also is much better and the durability of the lens also is much better. And the cost is almost the same, 3,500 to 4,000 rupees. So you can see when I want to do the superior part, I am just rotating the lens a bit and I can see the superior part of the angle also very clearly. Whatever bleeding at all, if you have the side port, if it is limbal and there are some vessels which are bleeding, because of this contact lens effect, the bleeding is arrested there and the blood doesn't come into the interface. And the suction is so good that when you try to remove the lens, you feel like those vacuum hangers which were available in the past, it is something that effective. You almost apply that much force to remove the lens from this surface. So always try to do this, practice this with the bang needle first. Don't penetrate till you are not confident. Once your wrist is free and once you are confident of identifying the angle structure, then you can proceed your journey with the bang. So you can see in this, if you are not confident and not properly looking, I touched the Descemet's membrane when I was rotating and trying to go to the opposite side. So accident trauma to the Descemet's membrane and to the ciliary body can occur if you have any tremors or if you are not stable during the procedure. So this is very, very important to take care when you are doing when you are mastering your intraoperative gonioscopy. Always make sure that there is no air into the anterior chamber and no air over the gonio lens also. Lot of time what happens is when you are doing the gonioscopy, your assistant who is standing next to you, he always have a habit of pouring saline over the cornea because that has been taught. Go on pouring saline. Arey pani dal, pani dal, pani dal. So he is mechanical worker. You are doing the gonioscopy and you will pour water on your lens and your view will be obstructed. So make sure that this is not done. So once you have practiced the gonioscopy, again the positioning of the head and the microscope back to the normal position, whatever visco is there, you can just wash it off. And when you do the procedure, I'll show you in the next few videos that when the excessive bleeding is there, how to arrest it. So this is another case. My talk is of 16 minutes, 2 talks, so I'm covering both. I'll take my 16 minutes and finish both the talks. So poor visibility is one of the factor. What happens in your learning curve, why there is poor visibility? This is a bad phaco wound. So if your phaco wound is too tight and you are struggling to do the phaco, especially the hard cataract, this striae and this stromal edema will be there. When you are reusing the lenses, you have to make sure that the surface of the lens is clean. There should not be any scratch. There should not be residual visco deposit with which you have ETO'd the lens. There should not be air bubble into the anterior chamber. Don't be lazy to wash away the air bubble or to remove the air bubble. Visco waste hota hai hone do, but air bubble should not be there into the anterior chamber. Always make sure in the learning curve what happens is when you are placing the lens, you are focused on it, you want to visualize the angle. In that process, you are forgetting how you are placing the lens. See, in this case, in order to visualize the lens, trabecular shock, I am lifting the lens. My wound is somewhere else and the lens position is somewhere else. I am lifting the lens, there is air, the air can go inside, the blood vessels can go inside, you can obstruct the angle by depressing the lens, there will be corneal rappelling effect. So these are the mistakes which one does in the initial learning phase. So always make sure what you are doing and never touch the tissue till you are not confident of what you are touching at. So this is the wrong placement of the lens, that I am entering through the side port but I am placing the lens as if I am supposed to enter from the main wound. So this is very important. Then another cause of poor visibility, as I mentioned, air bubble, fogging. If your draping is not correct and you place the lens, with every breath there will be fog which will be accumulating on the lens surface and that will also obstruct you. You can see in this video, This was a narrow pulpitular fissure, so you need multiple lenses. As you advance your journey, you should have multiple lenses, because sometimes in one lens you can't have the view and you place the other lens and the visibility will be there. So I would recommend you buy all those disposable lenses which are available, so that you don't get disheartened in the journey of your mix. So these are all poor visibility only. I am going to go up to the next topic.